So there have been a lot of developments in the treatment of advanced prostate cancer in the past few years. And what I've tried to do is distill the talk into three main topics. And the first of which is the use of early chemotherapy in metastatic prostate cancer. And then I'll talk a little bit about newer generation hormonal therapies, and then just touch briefly on the use of immunotherapy and radiopharmaceuticals. So this slide highlights new drugs approved for prostate cancer by the FDA over the past few decades. And you can see here that there wasn't a lot of activity for many years. And then in around 2000, there started to be some approvals, and then a rapid succession of drugs approved in this disease, most of which were based on survival endpoints. And this has certainly been a boon to the field and has improved patient outcomes. But as we have more and more therapies, as all of us who care for patients know, not all patients have the opportunity to be exposed to each of these therapies, and many patients don't respond. And so it's become even more important to learn how to best sequence these drugs and learn how to define patient populations who might benefit the most. And that's going to be the focus on much of my talk today. So any talk about advanced prostate cancer really has to start from the beginning, and many of you know who this is, Charles Huggins. And Charles Huggins was a surgeon at the University of Chicago. This is before there were urology subspecialists. And when he joined the faculty at University of Chicago, his department head said that he was going to focus on urologic surgeries, and he became interested in the prostate and then subsequently interested in prostate cancer. And he showed that depleting androgens in men would cause clinical remissions of prostate cancer. And this is a figure from one of his initial papers published in 1941, and it's quite interesting to see that even back then, intermediate endpoints were used, biochemical measures of response. So you can see here a patient who had orchiectomy, and he described in this paper that there was a decline in both an acid phosphatase that could be measured in the blood and modulation of an alkaline phosphatase as well. And of course, we know this is PAP now. The rest of this story is known, I think, to this audience. Huggins won the Nobel Prize for this work, and androgen deprivation therapy for the treatment of advanced prostate cancer has been the first-line therapy since that time, with nothing being demonstrated superior to this. And so we fast forward about 60 years, and probably the next major advance in the treatment of advanced prostate cancer is the demonstration that cytotoxic chemotherapy is actually active in this disease and can lead to a survival benefit. So you have two trials that were reported at the same time, one cooperative group trial and one industry-sponsored trial looking at docetaxel compared to the prior standard mitoxantrone, with both of these trials showing an improvement in survival with docetaxel. So what was alluded to already this morning, what do we do as medical oncologists when you have two treatments that work and seem to have non-overlapping toxicity profiles? Well, we try and combine these treatments together. And so it made a lot of sense to try this in prostate cancer. However, there was some rationale to do this in some investigators who thought that this might not be a great idea. So why would we want to combine chemotherapy and androgen deprivation? Well, of course, one reason is that there might be clones of cells initially that are resistant to androgen deprivation, and by adding a non-cross-resistant therapy, we could potentially eradicate those clones. In addition to that, some patients, because of the demographics of prostate cancer, might be too elderly to tolerate chemotherapy at the time of progression. The camp not in favor of pursuing this was largely based on the concern that androgen deprivation therapy would take cells out of cycle, and subsequently cells would be less responsive to chemotherapy. And while it's been a while since I treated breast cancer, if I remember correctly, we actually don't do this in breast cancer, particularly because of this concern. So how do we answer this? Well, we do a clinical trial, and this was done by Chris Sweeney and investigators through the ECOG, and this is the ECOG 3805 trial, also known as the CHARTED study. And what this trial did was randomize patients with metastatic prostate cancer to receive androgen deprivation therapy plus docetaxel or androgen deprivation therapy alone. You'll note that prednisone wasn't given with docetaxel on this trial. The primary endpoint was overall survival. And this trial went through a couple of iterations in terms of the design, and the sample size changed because of the inclusion or exclusion of patients with different degrees of disease burden. And this was defined prospectively on this trial as patients with high extent of disease or low extent of disease. And high volume disease in this trial was defined as having visceral metastases, 4 or more bone metastases. And this is, of course, somewhat arbitrary, but was prospectively defined. So here are the results of the charted study, overall survival. Adding chemotherapy to androgen deprivation therapy was associated with an improvement overall survival with a hazard ratio of 0.61, and quite impressive was the improvement in median survival here, which is something that we really don't see that commonly in advanced cancer, an improvement in survival about 13 months in this population with the addition of chemotherapy. Here's the subgroup analysis of this study, and when the patients were segregated by high volume versus low volume disease, you can see here that there was really a tremendous benefit in patients with high volume disease with a hazard ratio of 0.6 and a median improvement in survival of 17 months. A lot has been made about the results here. Low volume disease, again, the hazard ratio does favor chemotherapy, but is not significant. But of course, the median survival on both of these arms wasn't reached at the time of this analysis. So it's hard to say too much about low volume disease, although there appears to be a benefit in high volume disease. Adding a little bit of complexity here is that there has been a trial in a similar population of patients conducted in France, which didn't show a benefit. At GU ASCO, they went back retrospectively, segregated their patients into high volume and low volume disease, and again, it didn't show these same results. However, that trial was smaller, fewer patients completed all treatment, and these results, the results of the ECOG study, have been considered practice-changing by most in the community, although these results have not been published yet. One of the issues, perhaps limiting somewhat the impact of these results, is the way that we treat prostate cancer in the United States in this day and age. And of course, this study was done in these patients right here. But for better or worse, we do initiate a lot of patients on androgen deprivation therapy here before they have metastatic disease. And again, those patients wouldn't be eligible at the time of castration resistance for the ECOG study. Those patients really presented with metastatic disease, being hormone naive. What do we do when patients become castration resistant? Well, first, what is castration resistant? I think this is pretty straightforward, although I still do encounter some confusion about what this actually means. And it's quite straightforward, just as the definition states. So as we start patients on a GnRH analog or antagonist, of course, testosterone declines. And when testosterone declines, PSA also declines in the vast majority of patients. But at some point, even despite castrate levels of testosterone, which kind of a line in the sand is defined as a testosterone level less than 50, at some point, most men will start to develop a rise in their PSA. And of course, that is castration resistance. This used to be called hormone refractory disease. Of course, that was a misnomer. These patients do not have hormone refractory disease, and we've known that for quite a while for 2 reasons. One reason is because PSA is an androgen-regulated gene. So if PSA is rising, that tells us that the AR signaling axis in almost all cases is intact. And the other reason we knew this wasn't hormone refractory disease is because these patients could respond to additional hormonal manipulations. And what we know now is that these patients are actually hormonal ultrasensitive in many cases. So how does this happen? Well, under selective pressure of androgen deprivation therapy, there are a number of adaptive mechanisms of resistance that occur, and it's probably not as simple as one of these being at play in an individual patient. There's probably many mechanisms in an individual patient. But what we do know is that understanding these mechanisms better has really been critical to the development of a number of new treatments in prostate cancer. The end result of all of these is the same. You have restored AR activity and a rising PSA. So what are these mechanisms? Well, one is deregulation of the androgen receptor, and this can involve amplification of the androgen receptor. This makes sense. If there's limited androgen around and a prostate cancer cell upregulates the number of receptors that it has, then it's increasing the chance that there might be ligand receptor interaction. And so this was actually the basis for the development of a new generation of hormonal therapies, particularly enzalutamide. So enzalutamide is an androgen receptor inhibitor. It binds much more potently to the androgen receptor than bicalutamide or other first-generation AR inhibitors. In addition to that, blocks translocation of the androgen receptor from the cytoplasm to the nucleus, where it needs to do its job by binding to DNA. Enzalutamide, in the initial studies published in Science, was demonstrated to have activity in model systems of prostate cancer where the AR is overexpressed under a viral promoter. And so it was really developed for this particular situation that I'm referring to. Another mechanism of resistance that's been appreciated more recently and is really quite fascinating is intracrine androgen synthesis. So it's, again, been known for some time that there are alternative sources of androgens that lead to progression of patients with prostate cancer. And the adrenal gland is one primary source. But more recently, based on some really elegant studies, it's been shown that prostate cancer cells actually upregulate the machinery to synthesize androgens themselves. So what can we do about this? Well, that was really in part the basis for the development of Abiraterone. Abiraterone is a CYP17 inhibitor, originally developed to better inhibit adrenal sources of androgens, but later showed that these same enzymes are upregulated in prostate cancer cells. And you can see where CYP17 is in the adrenal hormone biosynthesis pathway. And when you block CYP17, of course, this leads to a decrease in adrenal androgens and a subsequent decrease in testosterone. But the other ramifications of blocking CYP17 based on the location is that you do have some decrease in cortisol. And what happens with this is when you decrease cortisol, that results in a loss of negative feedback. So ACTH goes up, and adrenal insufficiency isn't really the primary issue here, but because of the level of the blockade, when you have a loss of negative feedback and ACTH goes up, you have a marked increase in these mineralocorticoids, and that can lead to severe toxicities, hypokalemia, hypertension. And this is really why we give the steroids with Abiraterone, and that's my main point of showing this slide. We use steroids a lot in prostate cancer with different treatments, and we use them for different reasons. But this is why we give steroids with Abiraterone, to blunt the rise in ACTH and limit the side effects. So Abiraterone and enzalutamide have been studied in clinical trials, both post-chemotherapy and pre-chemotherapy. And the design and endpoints of these studies are really identical. Of course, because these drugs are orally administered and relatively well tolerated, it's the pre-chemotherapy space where this has really been taken up. And just to briefly show the endpoints, because they're quite impressive in terms of radiographic progression-free survival, this is the pre-chemotherapy study of enzalutamide versus placebo with a hazard ratio of 0.18. And this is the Cougar 302 study of Abiraterone pre-chemotherapy. So, of course, the question is, with these two drugs, which do improve survival post-chemotherapy, seem to improve survival pre-chemotherapy, and are relatively well tolerated, how do we know which treatment to use first? We don't have a great answer to that question right now. If you line up these trials next to each other and you look at the radiographic progression-free survival on both studies, quite similar. Overall survival, quite similar. Time to chemotherapy, quite similar. Response rates are nearly identical. And the side effect profile is nearly overlapping as well. And you'll note that compared to prednisone or even placebo, the toxicity rate is not all that much higher. So we don't have great data telling us which one to use first. What about using these sequentially? This is very commonly done in the clinic. We don't have really great data for this either, and the experience is limited to a series of retrospective studies that have been published so far. And I think what we do know from these studies is that there is substantial but probably incomplete cross-resistance between these therapies. So you can see starting with enzalutamide and going to Abiraterone or vice versa, rates of PSA decline are quite low, even though these look numerically higher with this sequence. If you look at the median duration of treatment response, it's really quite similar. While we don't have a study that will really define the best sequence right now, we do have a study that will hopefully tell us whether or not we should be giving these treatments together or as single agents. And this is the current study being led by Mike Morris through the Alliance, randomizing patients to the combination treatment versus starting with enzalutamide. Of course, not all patients respond to these treatments, and there is a substantial cross-resistance, so it would be a real help to patient care to be able to define which patients might be resistant to these therapies, and there is some headway being made in this regard, and this really has to do with this third mechanism of adaptive resistance, and this is alternative splicing of the androgen receptor. So like a lot of genes, the androgen receptor can undergo alternative splicing. This appears to be deregulated in cancer. The androgen receptor consists of a C-terminal ligand binding domain and an N-terminal DNA binding domain. So this is where androgens bind. This is also where enzalutamide and bicalutamide block the interaction. Once binding occurs, the androgen receptor translocates into the nucleus, where the N-terminal domain binds to androgen response elements on DNA and leads to transcription of AR-regulated genes and growth and progression of prostate cancer cells. If this alternative splicing occurs, then you might end up with an androgen receptor that lacks the ligand binding domain and only has the N-terminal domain. And of course, the consequences of this is that depleting androgens or blocking the AR is not going to help in these situations. These receptors are constitutively active and could lead to growth and progression of prostate cancer. So Dr. Antenarakis at Johns Hopkins came up with a very straightforward yet elegant way to test whether or not this made a difference in the clinic. And he asked the question, if we can detect AR splice variants in circulating tumor cells in prostate cancer, would this correlate with response or resistance to these androgen receptor pathway inhibitors? And here you can see patients who are enzalutamide treated or abiraterone treated, and these are waterfall plots based on PSA decline. So of course, going down means PSA's declined, and going up means that PSA is increased, an intermediate measure of activity in these patient cohorts. In the patients who are blue, did not have the AR splice variant in their cancer, in their circulating tumor cells. And you can see here that virtually all of the splice variant positive patients did not respond to these drugs. So very provocative data being replicated. What makes this even more interesting was this data was updated at GU ASCO looking at a population of patients treated with taxanes, and this does not appear to predict response or resistance to taxanes, which you might expect based on the mechanism of resistance, and of course the ramifications of that are quite clear. One could think about doing this test and determining which patient should go straight to chemotherapy versus maybe which patient should receive an androgen pathway inhibitor. Can we do anything about this? Well, there is some interesting data emerging in this regard. I mentioned that blocking the AR or decreasing ligand probably isn't going to do anything in this situation, but if we could deplete, if we could degrade the androgen receptor, well, that might be an effective therapy. So this is galaterone, and galaterone has a number of mechanisms of reaction, but one of those mechanisms is that it does indeed seem to degrade the androgen receptor. So these are 22RV1 cells, and 22RV1 cells express both full-length and splice variant androgen receptor, and with increasing concentrations of galaterone, you can see in this Western blot that the AR degrades. In addition to that, in this LUCAP 136 model, this is a patient-derived xenograft model from the University of Washington that's enzalutamide resistance. That treatment with galaterone led to a significant tumor growth inhibition compared to control. We have very preliminary data in the clinic This is a cohort of patients presented by Mary Ellen Taplin last year. And in this study, they didn't use the same exact circulating tumor cell assay. Here, they used an assay that they could detect either the N-terminus or the C-terminus or both of the AR, so sort of a surrogate measure of this splice variant. And in the small population of patients who had C-terminal loss, so these are patients who you might think have the splice variant present, here's the activity of Abiraterone in terms of PSA declines, and you can see there does seem to be activity here. So this has led to the design, to my knowledge, of the first clinical trial in advanced prostate cancer, in cancer, that is selecting patients based on a biomarker that's present in circulating tumor cells. So this study will enroll patients with detectable splice variant in circulating tumor cells and randomize them to Abiraterone versus Enzalutamide. How about the role of immunotherapy in metastatic prostate cancer? Well, we heard about this a bit already, so I'm just going to make a few comments. Sipuleucel-T is the first active cellular immune therapy approved in patients with solid tumors, and we already went over how this works. This is associated with a survival benefit, but of course the treatment is a little bit difficult logistically, and there's been some controversy as to where we best position this treatment, and this is a retrospective data. This is a retrospective study with all of the caveats associated with that, but I think it is somewhat compelling. So this is the phase 3 study of CIP-T, and in this retrospective analysis, the investigators separated the patients into quartiles based on the baseline PSAs, and then they looked at the outcomes in these separate quartiles. So if you started with a low PSA, the median improvement with CIP-T was 13 months with a hazard ratio of 0.5, and this seems to diminish as you have a higher PSA at baseline. So whether or not this means treating earlier versus whether or not this is just a surrogate for the biology of these prostate cancers more indolently growing, something that you might expect might be the setting where immunotherapy works the best, whether or not this is just artifact based on a retrospective analysis. Hard to know for sure, but it is food for thought. And is my time up?
You got a couple, go ahead.
So just a few comments about radium-223. So radium-223 is a radiopharmaceutical. It's a calcium mimic. You can see where radium is on the periodic table versus calcium. Radium's taken up by bone in areas of new bone growth. And why this might be an advance compared to older generations of radiopharmaceuticals is that this is an alpha emitter, and alpha emitters are a very short wavelength. And so the thought here is that by depositing in areas of cancers and leading to radiation exposure just to a very short depth of penetration, this will increase the likelihood of killing cancer cells but limit damage to the normal bone marrow. So radium-223 was studied in a phase 3 study, and of course the enrollment criteria are very relevant to how we use this in the clinic. These patients had confirmed symptomatic metastatic prostate cancer, had to have bone metastases, and couldn't have visceral metastases. And this, of course, made it into the label, so this does have implications in terms of how we use this treatment in the clinic. Interestingly, a survival endpoint was the primary endpoint of this study rather than pain like prior generations of radiopharmaceuticals. And of course, you all know that radium-223 did lead to an improvement in survival compared to placebo. And so for patients who are docetaxel pretreated or docetaxel ineligible and have pain and don't have visceral metastases, of course, this can be an effective treatment. So we have more and more treatments in prostate cancer. We're just beginning to understand how to sequence these drugs and which patients might be the best for which treatments. In terms of the next few years, we're going to see more agents. Some of these are Me Too agents, I think, although might find a place in prostate cancer and earlier disease states. But there are some very interesting mechanisms of action that are really new mechanisms that are showing activity in early studies. An increased understanding of the biology of castration-resistant prostate cancer, of course, has led to all of the current advances, and I suspect will continue to do so. We're going to continue to see an earlier use of treatments that have been demonstrated to have activity in patients with castration-resistant disease. And of course, some exciting data about new molecular diagnostics may be the first tool to allow us to select therapies in patients with advanced metastatic prostate cancer. And I think we're also going to see true hormone refractory disease, and this is the topic of a completely different talk, but in the setting of better and better androgen biosynthesis pathway inhibitors and androgen receptor inhibitors, we are seeing a change in the treated history of prostate cancer. So I will stop there. Thanks.